again, welcome to another episode of Accreditation TV. So we appreciate you being here today. We're excited. We welcome everybody who's been tuning into these things, and we're going to continue doing this, like we said, from now on with no end. But I'm excited today, not only to welcome you all that are here live, but those that are going to watch it in the future, and certainly our two subject matter experts who are not some of the frequent flyers that you've been seeing a lot of lately. But I'm Steve Sponbrook, by the way, CEO of MSL Healthcare Partners, and happy today to have Rebecca Maroon, who's one of our nurses and has a background in infection prevention, and among other things, and surveys with us. And also Russ Harbaugh, who's got a litany of things that he's been involved in, not the least of which he was one of the former presidents of ASHE, which is how I got to know him way back when. So we're happy to have Russ join our team. He joined a couple of years ago, kind of part-time, but is it okay to say real soon we're going to be your gig. So I'm excited about that. Depending on when you're watching this, if you're watching this in September, that already transpired. So anyway, if you're part of our MSL Ready Now network, and you want CECs, please jump over there and let us know. We'll make sure you get covered with that. If you're not one of the folks that's in our MSL Ready Now Connect level, let us know if you're interested. We'd love to have you join that. Also, if you have questions and you want to interact with us, put them in the Q&A. We can't actually chat with you, but we can answer questions in the Q&A. That's one of the confusing things about this. But anyway, welcome both of you. So we're going to talk about something that's near and dear to my heart for a variety of reasons. And that's infection prevention. But today it's about infection prevention and control and what surveyors are actually seeing or looking for. So I kind of want to just start with the very basics, which is, what started this to begin with, or what, where the requirements come from, which the CMS COPs basically say you have an infection prevention program. And Rebecca, since you're the expert in that, can you kind of give us the basics of what is expected to be in place there?
Well, that is a very loaded question, and there's a pretty good amount that goes into it. So I don't know if we have enough time to capture everything, but what is being looked for is that there is a fundamental program in the organization that has a cross-functional collaboration with the teams, that we're taking care of our patients, we're taking care of our employees, which includes our medical staff, our volunteers, our contractors, our students, even our visitors in our community. And how do we do that? We perform risk assessments, we do surveillance, data collection, we put programs in place to make sure we're doing all the right things to prevent infections or correct our processes. And we work a cycle such as PDCA, so we're constantly getting better. We're finding those problems, we're making them better. And this cross-pollinates an entire organization from top to bottom, side to side, and everybody must be involved. It's not just up to the infection prevention team to do that. We have to partner with our facilities folks, our dietary folks, our housekeeping folks, definitely the clinical team. That's what I'm originally part of. But, anybody who works in an organization, everybody has to walk the walk, talk the talk, and be able to demonstrate that to surveyors when they come to your organization.
Yes, that's a great summary and you talked about the cross-pollination and involving everybody, and that's certainly what we've been preaching all along, right? Is it takes a village, particularly with infection prevention. And we can talk about it kind of a little bit from a surveyor perspective too, but I think it's important to understand that, when we talk about accreditation, it's like we think about the fear of losing our accreditation or getting sideways with CMS, heaven forbid, and losing access to that funding, which in most cases would be catastrophic. But it goes, well beyond that in terms of if we have a hospital-acquired infection, what it actually costs an organization, right? I mean, there's real costs associated not only with ongoing treatment of that patient, but also, opportunity costs where, now we've got a length of stay that's much longer than it probably would have been initially. And so you've got a bed that's in use. And then there's the public relations issue that inevitably crops up because let's face, especially small communities, people talk, right? And yeah, I grew up in a small town, live in a really small town now, and it's like I mean, we have HIPAA, but once you get out the door and people start talking, not staff, but people start talking, and you get all those things. So Russ, from a physical environment perspective, I think a lot of times, I'll be honest, when I got into this business, which was a long time ago, 30 some odd years ago, I could not perceive a role as a facilities person in infection prevention. It took me a while. It took me a couple of years to go, oh yeah, we do play a part in that. From your perspective, what do you see? How do you see us being involved in this?
Wow. Rebecca did an amazing job as she encapsulated everything, right? She pulled in all the teams and that's perfectly true. I mean, because the fact of the matter is from the physical environment, when we kind of look at infection prevention, we kind of think of people who, are primarily clinical and they're looking at hand hygiene or they're looking at personal protective equipment or something like that, right? But when you look at it from the physical environment side, it's much more than that on our end, right? Because we're definitely responsible for, air quality. We're responsible for any type of construction, renovation, uh, water quality, all the different things that are involved in infection prevention, because we really are part of a team. We're integrated together, working together, utilizing tools like our ICRA, our infection control risk assessment on how we perform our jobs and our duties as facility professionals working in the hospital. Anytime we open up a wall, we remove a ceiling tile, we um, start a new project out, next to the building, we're digging up dirt, I mean,
Yeah.
all those things are captured under infection prevention because it affects our patients and it can affect our visitors and it can affect our employees as well. It's interesting because people ask me at times, do we do an ICRA or an ILSM? Do we do an ICRA on a clinical building that's not attached to the hospital? And it's like, absolutely yes, because we care about our employees and the patients that visit that clinic just as much as we do those people who are laying in beds in the hospital. So it's all encompassing in a sense.
Yeah. So I'm glad you mentioned that because I hate to say it because we are talking about accreditation, which by definition means we're talking about compliance. But the compliance bar when it comes particularly to infection prevention during times of construction and maintenance activities is really low. It's like if you have done anything at all, you get a check mark, right? But the reality is, I mean, there's a whole lot of opportunity there. But you touched on something about you talked about it's our responsibility for making sure the air quality is good, the water quality is good, and I kind of want to put Rebecca a little bit on the spot to speak for like all of her clinical colleagues and say, I mean, I would assume it as a nurse or even as a physician or any other clinical person, you take it kind of as a matter of faith when you walk into an isolation room or you walk into an operating room or you walk into any of the other spaces that are uniquely designed in a way to help provide some level of infection prevention and it's functioning the way it's supposed to function. Is that true?
Yes, and I will backtrack just a little bit because Russ brought up some very important points. Um, let's start with air quality. I started as a nurse over 30 years ago. All I knew is I needed to take care of a patient, get in the room. I mean, hand hygiene wasn't even much of a priority back then. We've come
Yeah.
a very, very long way, right? So we go in the OR, the doctor wants the room cooler, the nurses want the room cooler because it's so hot in there. But or it's too cold and they want it warmer. It can go either way. Is it appropriate to change those temperatures? Should we know what the humidity is? 30 years ago, absolutely not. But the pendulum's going the other way. And clinical staff should have a generic idea of what's expected and why it's important. So we are getting that education. We are getting some of that training. It may not be in the forefront of what we look at, but we do need to pay attention to it. You brought up construction. Had a very personal experience with one of the units in the organization I work in. There was construction going on in a department, but the ICRA barrier was not sufficient at all. That became a finding because the nursing staff, the clinical staff, did not know to stop the line and say, "We have a problem here. You know, dust is coming through. The air is flowing the wrong direction." So we have to have enough understanding as a clinical personnel to stop the line and make sure everything is correct, because we can have significant problems and bad patient outcomes when all those factors aren't lining up like they're supposed to. So the pendulum's moving. We're getting there. It's not complete yet, but we are making strides to understand more about the physical environment and what's happening with those changes that need to happen. Because what I've learned in 30 plus years of nursing, the hospitals change constantly.
Oh yeah.
There's always a
Yeah.
construction project going on. There's always a hole in the wall getting repaired. There's always a door that's not lined up appropriately.
Yeah,
So we
and
need to be
equipment breaks
cognizant of
down,
that.
right? That's the thing. Equipment breaks
hmm
down, and
Correct.
sometimes things aren't maintained the way they're supposed to be maintained. You can get into all kinds of discussions about filtration efficiencies, and you get from with Russ and I, we live in that whole world, down in the basement or out in the plant building, and it's easy to kind of feel disconnected from the patient. But I'm becoming kind of infamous for always bringing some kind of aviation analogy into every one of these videos, and I'm sorry about that. And please put in the chat if you're tired of me talking about aviation. But when I look at you look at like the Blue Angels or the Thunderbirds, when they go out and they do a show, the maintenance folks, the plane captains that prepare those aircraft before they fly, the pilots walk out and they take as a matter of faith that airplane is ready to go, right? And I kind of see our role as being like those plane captains that are providing to the clinicians and the pilots a piece of equipment that is absolutely ready to go, which means we've got to do our own due diligence. I mean, you touched on the ICRA, and when I used to go out and do surveys all the time and do a lot of teaching, I would talk about the ICRA because we usually ask the question and say, well, so whenever we do construction, we do an ICRA. Well, what about regular maintenance activities, plunging
Great.
toilets,
Yep.
fixing leaks? Do you ever think about that? And there's, well, no, it's not required. Is it a good
Mm.
idea? But, and I used to say the dust don't know and it don't care. Right? It really doesn't. If it's
Really?
Yeah, if we're out there generating dust, or we're agitating mold or whatever for whatever reason,
hmm
and it's I used to have contractors that would come up to me and go, "Hey, we're doing all this stuff we're supposed to do, but we watch the maintenance guys walk right by and breach it. How are we supposed to get our people to stay in line?" And fortunately, over the years, I think we've changed that. I don't see that nearly as much as I used to, but kind of getting back to the accreditation side of this. Like I said, I don't get out much anymore, but when I used to tell them folks, I said, don't tell me if your EVS is outsourced. I'll tell you after about 30 minutes of doing a building tour, and kind of make a game out of it, right? Because it usually was pretty obvious. There was a line, literally a line in the contract where they cleaned and then the hospital had to take over. And what I normally would find, and I think it still exists just kind of based on the few samples that I get a year, that there's a gap because the responsibility's never actually given to whoever's supposed to go above that line that's in the contract. Have y'all seen that? Or
Oh yeah, I definitely see it when I go out and survey, Steve. It's amazing sometimes what I do see. What we do witness, because it is everybody's responsibility. But as Rebecca talked about, it's the education, right? And who's responsible for that education? And it isn't solely upon the infection control or infection prevention people. It's everyone, and really it comes back to the physical environment as well. And when we see things in facilities and hospitals, and we see that clear line that you're talking about, you have to bring it up. I mean, when we talk about accreditation, there is a place in accreditation for cleanliness, right? And
Yeah.
maintaining the facility. And I want to backtrack just a little bit too, because I appreciate the education piece that Rebecca brought up, because I've had the opportunities to speak with the epidemiologists and the folks in infection prevention and talk about the infection control risk assessment. And I love the fact that a lot of facilities, their infection prevention folks attend classes and they gain that education and knowledge. So it's just not the facility side saying, "Well, yeah, this is our risk assessment, and don't worry about that," because that's not going to affect it. They'll call them out on it, right? Or when they walk through the projects, when you're doing a construction project and you've posted um, your risk assessment on the outside of that construction project, they know how to read it and they know what's expected. And then they go back and enforce that as well, right? So
Mhm.
making sure that folks are truly educated and have that ability and opportunity to do that makes a huge difference in a healthcare facility. It's when you start seeing this, you know, people pointing at each other, then there's a problem, right? And then you have to provide that education. And you brought up another good point, Steve, when you talked about the risk assessment, the ICRA. Now we have our ICRA 2.0, right? And they went from class 1 through 4 now to class 5. And so increasing that additional class allows opportunity for maintenance and repair, the number 1 class, right? That allows them to work on equipment or do preventative maintenance or various things like that they're not going to stir up dust or create dust or sanding or cutting or whatever. So the whole process, that whole education tool is there for a purpose, and it's there to benefit everybody in the organization if they exercise it. And I think that's what we see when we go out and we survey. We sometimes see folks not using the tools that are provided, and they're there for them and they're there for their patients as well.
Or they're using them in a way. I mean, this is going to sound really jaded. I'm getting old. It's like I'm starting to get sarcastic, I guess. But they do it just as a matter of showing compliance, and they don't really do it with I don't want to say in good faith, but they just go through the motions, right? And I think you get into a situation, especially, and one of the things I like to emphasize whenever I'm out there and teaching or whatever is that our environment, and actually, Rebecca, you touched on it, our environment's dynamic. Things change. Like we could do this ICRA for maintenance. And what I used to preach was let's do a blanket ICRA for the whole hospital and say this department's a 1 and this is a 2 and this is a 3 and this is 4. But the problem with that is that changes daily, sometimes even more than daily. I mean, you take behavioral health, for example, from an infection control perspective, it's relatively low until you put someone in there that's on an oncology regimen. Then all of a sudden, that changes temporarily. And that's, I think, a high functioning organization, high reliability organization is going to have a mechanism to capture that. And that's, through daily huddles or whatever, whatever they're using to communicate. It's like, hey, we've got, patient A in behavioral health and they're immunocompromised. So for the next, until I tell you otherwise, you guys need to treat this as a high risk environment. Does that make sense? I see Rebecca nodding her head. And,
Yeah.
Well,
and I think we're all hitting on the fact that, yes, education is extremely important, but are we actually walking the walking, talking the talk? And the staff can speak to it and they know why. And that's where we struggle a lot. We do the education. Do we ask for the return demonstration? And do we go back and repeat it to be sure it's really hardwired? And I think there's often opportunity there because, yeah, we checked the box. We provided the education. We saw it return demonstration maybe once, maybe twice. But if we're not doing competencies on this routinely or checking daily, to your point, we may just check the box that we checked it, but do we really understand what we're checking off? And that is something in a survey, the surveyors are going to be looking for. They're going to be looking to make sure everybody's on the same page and can explain what's happening and truly understand it.
and doing tracers, watching tracers, to your point, making sure that we're going back and checking, because that's closing the loop, right? I mean, and this is what I see quite often. Let's talk about operating rooms and pressurizations, air pressure or temperature and humidity, right? And looking at those, and now ventilation policies are extremely important. The Joint Commission, it's one of the high sightings is your ventilation policies is not maintaining the proper temperature and humidities in your operating rooms and how they control that. And so how do you control that? Well, that really has to go, it has to start in the operating rooms, and then it filters down to the physical environment where, they have to be able to, provide information. Let's say, for instance, on a doctor who wants to lower the temperature because he's performing a hip surgery and he wants it cooler in the room, but it raises the humidity, right? So what do you do, and how do you track that? So I see what hospitals are doing a lot of is that they're calling down to the maintenance department and they're asking them to lower the temperature. The maintenance department in return is asking to see what temperature they want, what duration they want, what's the case number, and who's requesting that, so that when facilities is under document review and they see those temperatures, or humidity levels, they can trace it back. Or if there is a hospital acquired infection in the operating room, then the operating room can go back. They can track back to, what was requested and when and for how long and so forth and so on. So that education is so important. When I look at an infection control risk assessment, and I look through a completed one, what I try to find is how did they close the loop? Who initiated it? What work was done? What kind of education and communication was delivered to that floor, to that unit, to those employees, so that they knew that there was an infection risk assessment being performed and there was going to be something there that could create dust or, whatever. The point being is closing that loop to see those emails or to see those education pieces, and then, be able to see that particular project closed out and when it was completed. You just see, like you said, they're checking the check boxes, but are they doing the work?
Well,
And I think
you touched on something that was really important, and I kind of want to emphasize it because 2 weeks ago when we were talking about equipment, loaner demo equipment, we talked about how important it was to tie that especially demo equipment, to a case number or to a medical record that, hey, we used this device on this patient. So if there was an issue, we could tag it back. And you just mentioned that when we go out of, I say out of spec, but out of the normal criteria for temperature or humidity, that we track that back to the medical record. And I think that's really, really important to be able to do that, because there are legitimate clinical reasons to go below or above. I had that explained to me in a very succinct and direct way from a surgeon one day. You can draw your own conclusions what that means, but very direct and succinct. But and honestly, one of the challenges on the facility side is we don't often get that reason. We're being set. We're saying, hey, look, we don't want to go there because this is what's going to happen. Our relative humidity is going to shoot up, and we're going to have a problem. And surveyors, SEMA, whoever, DMV, George Bush, we're going to get in trouble. It's going to be on me, right? But
right.
There's a good clinical reason, and we can demonstrate that. To your point, this is why we were out of range. This was the clinical criteria that was used. This decision was made by a clinical person on behalf of the patient. And we know because we were only out of range for X number of, whatever that time period was. We've done our surveillance. We've done the data gathering that Rebecca mentioned. There's been no ill effects. We should, in most cases, get by that scenario without any kind of a finding, I would hope.
Yeah.
Well, to your point, Steve, as long as you can tell the story, You have the data to support the length of time, the reasons, the who, what, why, where, when's, all that documented. You're right. You have everything you need. And the other piece of that is what's getting up to leadership. What are they learning from what's happening? What are they involved in? Because they have a big stake in this. They need to know what's happening in the organization and be able to, understand it, speak to it as well, and guide the organization how they want to go with infection control and what they will accept and won't accept.
You
So,
know,
we that's part of this. So if we're out here acting and not sharing, that's an issue.
yeah.
Yeah.
That ventilation policy is so key because it should be a multidisciplinary group. When you talk about leadership should know what that's going on, well, you need to be doing what you say. So if you say that if you're going to be out of range, you're going to document it in the operating room, you're going to document it at facilities, and if you're out of range, if your humidity level, you can be out of range on temperature, but your humidity level is just a no-no. It's a absolute, right? And
Yeah.
so what does your policy say? And then are you abiding by your policy? If it's 1 hour, if it's 2 hours or 4 hours, are you going to stop doing operations? What are you doing? And so my recommendation is really to create an ironclad ventilation policy and have it vetted by your accrediting body, because it can get you in trouble if you don't have that in place. You just can't say,
Yeah.
well, it was only going to be for an hour. That doesn't
Yeah.
work. It,
Yeah.
it has to be written, and then it has to be followed.
And it has to be, I think, to your point, I know we keep saying multidisciplinary, and we've said that probably, if it's on your bingo card, you won. We've said that a bunch of times. But, when we write that policy as facilities people, we say we're out of spec, we don't do surgery. Well, that's a little bit on the extreme side of that equation, right? I mean, there is a tolerance level that we can create, but we can't make that in a vacuum. We have to include our clinical colleagues, infection prevention, the people who are doing the surgeries. There's so many. I mean, I'm learning so much about how these types of cases where you want it to be super hot in the OR, and then you want it, and maybe in that same case you want it to start super hot and then go super cold. Well, if we start super hot and go super cold, guess what? The relative humidity is going to spike. And as much as we'd like to change that, that's the laws of physics, right? So having that, I agree with you, having that done in advance is a really good thing to do. And I think it's not only, it might be hard to get it vetted by the accreditation organization, but you could definitely vet it internally with your own leadership team, making sure it passes the quality test, the infection prevention test, the, clinical staff test. And if everybody's in agreement that this makes sense, then I think you can, as Rebecca says, tell the story and make the argument that you're managing your patients. Kind of getting back to the accreditation piece from a data perspective. What would you expect, putting your surveyor's hat on for a minute, Rebecca, what would you expect to see hospitals collecting? I know they're the obvious ones, the CAUTI and CLABSI or whatever, the ones that, where everybody's doing because they're, but what would you like to see in a best practice?
Well, I think it's organization dependent. So, what does your organization have going on? And that's where your infection control risk assessment comes in play. So, yes, to your point, it's the standards, CAUTIs, CLABSIs, other emerging infections that may be happening. But it could be very regional, independent, or uniquely specific to your organization. So, that's kind of a loaded question that I don't know that I can give a true definitive answer for. What happens on the East Coast and what we look for may be a little bit different than the West Coast. Case in point, right now, Ebola's on the rise in the Congo, right? It's in the news. And I live on the East Coast, and I live an hour outside of Dulles Airport. And this is going to be a timely statement, but all flights now have to go through Dulles. Well, I live an hour away from Dulles, and there's only one hospital, in between me and that airport. So we're going to be pulling out a policy in the organization at the hospital where I work to make sure we're ready in case somebody ends up in our area again. We've got everything in place. We've got the right people trained again because this is kind of fallen off our radar.
Yeah.
So it can be very timely with what's happening in the world and what's happening locally, what's happening in the community, that you have to pay attention to. So that's where your risk assessments come to play, where you really need to hone in what's important.
Classic
And how
low
old is your
volume, high
building?
risk, right?
Yes,
I mean,
that
and
is for sure.
you actually answered the question exactly the way I hoped you would answer it, which was it depends on each organization because it is
Yeah,
organizationally specific, right? And that's, it
right.
might be what is your biggest service line? Maybe you should be measuring, or where have we seen pockets of issues? Maybe it's in, the 3As of the world. I'm not picking on you, but it's in Department 3A. There's been, for whatever reason, there's been an outbreak there, and it might be facility related, it might be hand hygiene related, it might be who knows. But
Right.
so it is very, and
Well, to your point, hand hygiene should be everybody's priority. That should be on everybody's list and constantly working it because it touches everyone who's in the organization, whether you're a paid employee, a volunteer, even your visitors. Everybody should know hand hygiene is a priority in the organization, and there should be resources to be able to perform hand hygiene everywhere you turn.
yeah,
So everybody's measuring it and focusing on it because it is the number one way to prevent the transmission of organisms. So break that cycle, do hand hygiene, and that's significant when you tackle that and master it.
yeah. I mean, it should become second nature, right?
Yeah.
I mean,
Correct.
when you get to a point where you've trained it into people, and I had the honor really of observing a nurse for half a day and a pediatric ED the other day, and she was relatively fresh out of school, but I was chasing her around trying to keep up. It was killing me. And she actually pulled a patient out of the lobby because she recognized it was in respiratory distress. And, we're headed towards the room, and she grabbed a mask and handed it to me. And she goes, "This kid probably has RSV. You might want to wear this." And I'm like, she was, and going to your point, taking care of everybody, all the stakeholders involved. And that left a really profound impression on me. And at that point, she had no idea what I did for a living. So I think it actually came from the right place. While time flies when you're having fun, we're a little bit above 30 minutes, but I don't want to cut this short. If you guys have other things you want to talk about in terms of, what surveyors are going to look for, what are some best practices that you can think of?
Steve, I know you're probably going to touch on this in the future, but I would be amiss if I didn't speak up a little bit about water management and
Sure.
making sure that that your organization has a well-structured water management plan and that it's driven by your infection prevention folks to help, to make sure that your water quality and your water testing and that your facility maintenance teams are working on dead legs and your EVS folks are doing flush Fridays and they're, dropping the shower heads and flushing, unused areas and making sure that you have something in place that really focuses on that water management. There's other nice things that are coming down the pike, like ST 108, which would be your cleanliness of your water. That's a whole nother topic,
A whole
definitely.
other episode, yeah.
Yeah,
After that,
absolutely, absolutely. But I mean, the surveyors really are focusing on your water management plan. So having a good water management plan in place is key.
yeah, I mean, absolutely. It's we're learning that's the one thing I will say is from an infection prevention perspective, we've evolved tremendously throughout my career from where we never thought about water management. We never thought about airflow really. I mean, infiltration deficiency. We certainly didn't think about construction risk until, the year 2000, which seems like well, I started to say it seems like it was decades ago. Well, it literally was decades ago. But, I mean, we just didn't think about that stuff. And now, look where we are today, where there's a whole lot of people are much more knowledgeable across the organization. But I think we talk about going back to what a surveyor's looking for and what they see is you want to see everyone involved, right? You want to see that EVS person that's keenly aware of what they're doing, that is practicing good hand hygiene. And you want to see, the maintenance people understanding how important properly sealant filters, for example, are. And, just all of those little things when you're surveying and you see, it's not the obvious things I think that surveyors pick up on. And at least from my perspective, the obvious things like here's the data that we collect and, here's the sign that we have about hand hygiene. I mean, that's the stuff they want us to see. It's the little stuff that you see when people do the right thing, when they don't realize you're looking, that leaves that impression, right? And it all goes back to education where we started, I think.
Yeah. Yep. Looking at those ice machines and making sure that, folks are taking care of it. It's kind of interesting, and I'm just kind of digressing just a little bit here, but daily safety meetings, and every Wednesday you report out on the percentages of how many surveys your staff took on hand washing. What did they observe? How many people washed their hands, or used their alcohol hand rub? Those are key things and easy things, but just bringing it to people's attention, getting it out there in front of them and reminding them, and having those observations and collecting that data, like you said, so that you can, feel better about what your organization is doing. I mean, it's there for a purpose. It's there to protect those patients and protect the employees and the visitors as well. But really taking good care of our patients, that's what our whole goal is to make sure they don't get sick in our hospitals, from something that we could prevent. And I think that's important.
And I think it's incumbent upon the facilities people of the world to make sure to never assume that the clinical people are fully aware of how the building functions. I mean, we need to educate them and they need to educate us. I mean, it needs to be a constant flow of information back and forth. I've experienced it where we put immunocompromised patients into airborne infection isolation rooms. And I mean, everybody can draw their own conclusion as to what happened with that. But that was literally the person that made the decision. It's like, well, I saw the word isolation. I thought that was the safest place to put this person. And they just didn't understand. And when we explained, they were horrified. I thought they were going to cry. And so I was like, wow, okay, there's an opportunity here for us to help them understand the difference between protective and negative isolation environments. Protective environments are pretty rare in hospitals, other than ORs. But at any rate, anything else you guys want to bring up about infection prevention?
The only other thing I would like to bring up is, and you've touched on this, is PPE. And that, I think clinical staff do a relatively good job with PPE most of the time. But when we get outside of that clinical setting, sometimes our EVS staff, our dietary staff, and our facilities staff, and I hate to pick on them, but there's so many times when, you go, they're up in the ceiling and water drips down on them and they know they were up there for potential water leak and they don't have the appropriate PPE on. So it's incumbent upon everyone to do the right thing. And then it comes down to education, making sure everybody's doing it consistently all the time when we're supposed to be, wearing that PPE. And for every aspect of infection control, if we had to pick one word, I would pick accountability. We have to be accountable for our actions and learning and doing what's right.
Yeah.
And I will leave you with that.
I would be that guy on the ceiling without the PPE on.
I figured.
Yeah. It's one of those things that doesn't happen to me. That we all have a little bit of that, but yeah. So that's probably not a positive note to leave, but
and
we appreciate
it's a
y'all.
real note, though. It's reality.
It is reality. I can tell stories, but I won't. I appreciate everybody tuning in. Hopefully we got your questions. And if we did not, we'll answer them via email. If we had actually, well, we got your email because you logged on to this, but, so we'll reach out to you again. If you're part of our MSL Already Now Connect and you want CACs, CECs, easy for me to say, jump on over there and we'll get those to you. And we will see you all on the next one. Thank you both, Rebecca and Russ, for giving us your time today. We appreciate it. Your expertise was
course.
perfect for this. So we look forward to having you on. And, Russ, I want you back to talk about some water management here pretty soon.
Yep.
So you guys have a great rest of the day, and we will see you in the next one.
Thanks. You bet.